All right, let's start today's clinic. Today we're back to quarantine clinics after uh, a gap of a couple of weeks. We took 8 clinics before. We took all the basics of neurological examination. We took approach to different cases that students normally face in their exams. We took hemiparesis, quadriparesis, paraparesis. We took how to approach a case of neuropathy, myopathy, and how to approach a case of cerebellar dysfunction. So then we were on a break for a week or so. We took a couple of quarantine Sunday topics of neuroscience. We took memory, music, and language. And this week we'll come back to some core neurology. And we'll do 5 topics in this week from Monday to Friday. And today we will take movement disorders, and tomorrow dementia, and day after tomorrow we'll take motor neuron disease. Now, the purpose of this clinic is not to give you an exhaustive description of every movement disorder there is, because that would take a lot of time. What I would like to do instead is to just give you a concept as to how you will think of movement disorder. So when you get a case of movement disorder, uh, what should be your approach, and even when as a theory question, how should you think of movement disorder as a whole? So let's get started. When we think of movement disorder, what we essentially mean is that there is something wrong with your movement. Now, the thing with movement is that it can be voluntary or involuntary. And obviously, when we say disorder, we mean that movement is happening in an involuntary way. Because whatever movement happens in a voluntary way, we will not consider it as a disorder. So in this, what is important to know is that the brain circuit that we use for voluntary movement is the same that is involved in involuntary movement disorders. Okay, so we will be discussing what is the normal movement brain circuit, because that is very vital for you to understand how that circuit can get broken, and therefore how can there be a movement disorder. Now, keeping that aside for just 1 second, if there is a movement disorder, what can be the types of movement disorder? There could be either excessive movement or decreased movement, right? So either you are moving too much or you are moving too little. And what this is known is hyperkinetic movement disorder or hypokinetic movement disorder. So this much is logical. So if somebody comes to you with a movement problem, that means that either they are not able to move as much as they would like to, or they are moving more than they would like to. Both of them is an issue, and both of them are completely different sets of diseases. But both of them will have the problem in the same movement circuit. Okay. Now, what can be the disorders that would cause hypokinetic, that is, movement less than what is needed? So the classical disease of hypokinetic disorders is Parkinson's. Now, when we say somebody has Parkinson's, that what we are trying to say is that they have a hypokinetic movement disorder that is related to the brain circuit. Now, there may be patients who will come to you and who are not able to move as much, where their brain circuit is normal. For example, what if somebody has a joint problem? What if somebody has rheumatoid arthritis and all their joints are paining and therefore they're not able to walk? So when you see them approaching and you'll think that they're not walking as quickly as they should be, you might think that, oh, this is a hypokinetic movement disorder, and it's correct. But it is not because of a problem in the brain circuit. Therefore, it is not a neurological hypokinetic movement disorder. It could be a joint problem. They could have hypothyroidism. Hypothyroidism will lead to decreased movement, but that again is not a neurological problem, it's an endocrine problem. They could have something called as ankylosing spondylitis, which is again a joint problem. All their joints become stiff, so they're not able to walk. So there are other causes of somebody not being able to move as much, but today we are mainly interested in Parkinson as a part of hypokinetic movement disorder. Okay. Now we will talk about what is Parkinson a little later, but I just wanted to give you an idea of where in the flowchart Parkinson lies. So Parkinson lies in the hypokinetic involuntary movement disorder. What about hyperkinetic movement disorders? Now, hyperkinetic movement disorders has multiple types of diseases under it. So the main ones are, there are 6 of them. There is something called as athetosis, balismus, chorea, dystonia, tic, and tremor. And there is another one called myoclonus. So there is athetosis, balismus, chorea, dystonia, tic, tremor, and myoclonus. Now, we are not going to go into the detail of each one, but what I am going to do is to give you a concept as to how all these disorders can happen in the brain. Now, all of this happens secondary to some problem in this circuit. So this is the overview. And all of your movement disorders, everything that you will ever read in movement disorder comes in this page, which is that movement disorders is an involuntary state of movement. It can either be hyperkinetic or hypokinetic. Both of them are because of some problem in your brain circuit. If it is a hypokinetic, it is something to do with Parkinsonism. And if it is hyperkinetic, it could be one of these 7 disorders. Now, this is your overview of movement disorders. Now, to understand more about movement disorders, you need to understand more about movement itself. And once you understand movement, then you can go into the circuitry of movement. So let us talk about movement. Let us talk about what happens in the brain when you move. So you want to lift your right hand. This is where we will start from. You want to lift your right hand. The command for moving the right hand, and if this is the brain, and this is the right side, and this is the left side, then the command for moving the right arm will come from your left motor cortex. So this is the left side and this is the motor cortex. So there is a motor cortex on both sides, but your left motor cortex will give the order to move your right arm. And this we have already covered in our UMN and LMN lesion, but I will just cover it again. Your left side of the brain releases your pyramidal tract. So this is the pyramidal tract. The pyramidal tract will come down. It will cross at the level of the brainstem, and it will come down the spinal cord and then exit the spinal cord and then control your limbs. So there is contralateral representation in your brain. So your right side is moved by the left side of the brain. Now, we are not interested anymore in what is happening below the brain. So we are only interested in what is happening in the brain. So in the brain, inside the motor cortex, how does movement start? How does movement happen? So today, what we are going to be discussing is the movement circuit that happens here. So the whole movement circuit is in this area. Okay. So we'll now discuss what are the components of a movement circuit. So what happens in your brain when you decide that you want to lift your right arm? So for that, there are three things you need to know. First is that your entire movement happens in the frontal lobe. So this is your frontal lobe, and your entire movement happens in the frontal lobe. Now, when you decide to move your right arm, what are the steps that happen? First, you decide. So that decision making happens in the prefrontal cortex of your frontal lobe. So this is the prefrontal cortex of your frontal lobe. This decides that, yes, I am going to move my right arm. That is just a decision. Aage piche kuch nahi. It is just deciding that I want to move my right arm. What this does is, it conveys this decision backwards. Now remember that your primary motor cortex is somewhere here. So this is the part of the brain that does the final movement. So the final movement is done by your primary motor cortex. But before the primary motor cortex can do that movement, it has to reach from here to here. And the entire story of today's discussion, that the entire movement circuit happens in this area. What happens from the time you decide to move your right hand to the point where your right hand actually moves, that is the movement circuit. So your prefrontal cortex has decided, I want to move my right hand, but it has not planned anything. So the part of the brain that plans how to move the right hand, should I lift my shoulders first? Should I lift my elbow first? Should I extend my fingers first? How to move my right hand, that plan happens in this area. And this area is something called supplementary motor cortex. Now, the supplementary motor cortex lies between your prefrontal cortex, which decides, and your primary motor cortex, which actually does the movement. And what the supplementary motor cortex does is plans movement. So the supplementary motor cortex has a lot of plans. It has plans of moving the right limb. It has plans of moving the right arm, the right leg. It has different plans for different purposes. Suppose you want to move your right hand to lift a glass. The plan for that is different from moving a right hand to answer your phone. So every movement has a plan, and all those plans are stored in the supplementary motor cortex. So as soon as your prefrontal cortex decides that I want to move my right hand to lift up my phone, the supplementary motor cortex searches for the appropriate plan, picks it up, and then sends that plan to the primary motor cortex and says, execute. Understood? So this is the straightforward route. This is the basic of how, from your will, from your choice, when you choose to do something, to the point when it actually happens, this is the flow. Now, of course, it cannot be so simple. We'll get to the next level of complexity in just a minute. Before that, you have to know, inside the primary motor cortex, how is our body represented? So how does the primary motor cortex know exactly how to move only your right hand and not your right leg or your right face? So the reason that that happens is that Suppose this is the left side of your brain. The primary motor cortex is arranged like this. Every part of your body has a representation in the brain. So if you have a right index finger, then there will be an area of the brain which is only for your right index finger. And your right elbow will be somewhere here. Your mouth will be somewhere here. Your legs will be here. So every inch, every joint, every part of the body that you can move has a representation in the brain. So if your body wants to move only your right index finger, then it will specifically target this area and nothing else. So that is how it can very specifically move only one part of your body. And this representation is what is known as homunculus. Homunculus is a Latin word for little man. Now I have actually taken a photo of this to show you. So if you can see this, this is the way the body is represented in the brain. So this is the right side of the brain, and you are actually looking at the brain from behind. So if this is the brain, you have taken a section like this and you're looking at it from here. So this is how the body looks. So you have the legs dangling here, and then your hands, and then your eyes, and then your mouth, and then your tongue. So there are a couple of interesting things to note here. One is that you can see that a large portion, like from here to here, is dedicated only for your face and mouth. So this entire part is only your face, mouth, and hands. Whereas your stomach, your shoulders, your hips, your toes, your legs, that entire part gets such a small area in comparison. So what this means is that for your brain, your face and your hands are much more important than your tummy, your legs, as far as motor movement is concerned. So this is why we are able to do a lot more complicated things with your fingers than you are able to do with your toes. Because for the simple reason that your brain controls every tiny aspect of your fingers, but not so much in your toes. So this is the homunculus. This is how the motor cortex is represented in the brain. And this is the representation in the primary motor cortex. So that is that. Now coming back to what we were talking about initially. So this is the primary motor cortex, and this is the supplementary motor cortex. And this is your prefrontal cortex. Now your prefrontal cortex has decided to move your right hand. Your supplementary motor cortex has made a plan. So ideally, you would think that the next step is that the supplementary motor cortex will directly tell the primary motor cortex to move. But it doesn't happen like that. In the brain, whatever needs to happen, there has to be a check. Something like a confirmation, like we have to see if, are you sure you want to do this? So just like in your computer, every time you try and delete something, the computer will ask you, are you sure you want to do this? Similarly, in the brain, everything that happens, there is a confirmation. So you have to basically ask permission. And the interesting thing is that you have to take permission from some different part of the brain, not the same part. So in the case of movement, that permission comes from this part of the brain called as basal ganglia. Okay, now here we will pause. The basal ganglia is something that you may have all heard about, but uh, it has always been, even when I was in MBBS and even in MD, it has always been a tricky subject. It's always been a complicated concept. So we'll pause here. Are there any questions so far regarding how we decide to move and the planning of the movement and anything about the homunculus? Is there anything that you need me to go over again? You can ask now, and then we will go into basal ganglia because that is a whole other topic. All right. So coming to the basal ganglia. Now, remember that the whole idea of basal ganglia, the whole purpose of basal ganglia is to give permission for the movement. Okay, so the basal ganglia is continuously checking whether each movement is necessary, and if it is necessary, how to execute it. Okay, now I'll get to that. First, let us talk about what is basal ganglia and where is basal ganglia. So let's do the where first because that is easier. The frontal lobe is here, and here is the parietal lobe. The basal ganglia lies somewhere in the depths of the brain. Okay, so it is not on the outer part, it is in the inner part. So when we are looking from outside, you can't see the basal ganglia. What you are seeing is the frontal lobe, the parietal lobe, the occipital and the temporal, because these are on the outer surface. But the basal ganglia is inside. So to see the basal ganglia, we'll have to cut the brain. So that is what we will do. We'll cut the brain. How do we cut the brain? Let's cut the brain like this. Okay, so we'll cut the brain like this. So then what we get is, we'll get the ventricles here, and here we will get some egg-shaped things on both sides. Okay, so now we are looking at it from above, and we'll get these circular things that are in the depths of the brain. So when we see from outside, you won't be able to see them, but when we cut them, we can see it. Now these are the parts of your basal ganglia. Now what are these called as? So this part is known as caudate. This part is known as putamen, and just next to it is globus pallidus. This part is the thalamus. Okay, and a little below this area, let's remove the thalamus from here, say thalamus, and a little below this area you will have the midbrain, and in the midbrain you have something called as subthalamic nucleus and substantia nigra. Okay, so that is a lot of names, and obviously it's scary to suddenly be introduced to a lot of names, but this is all the parts of the basal ganglia that I'll talk about. You have caudate, which is here. You have the putamen and the globus pallidus. You have thalamus. You have subthalamic nucleus and substantia nigra, which are both in the brainstem. So these two are in the brainstem. And everything else is higher up in the cortex. All right, now take a breath and think about what is the concept of what we are discussing. What is the point of the whole thing? The point is that using all of these, caudate, putamen, thalamus, subthalamic, and substantia nigra, all of this have to work together. So think of it like a back office. So think of the basal ganglia like it's a back office, and you have your field team, and there are field teams here, and this guy has to ask permission to let this guy do something. And so the back office has all these workers, and these workers will convey the message to each other and then finally come up with a conclusion. That is basically what the basal ganglia is. The basal ganglia is a series of workers who will communicate with each other and try to decide and finally come up with a plan of action that either to let somebody do something or not let somebody do something. Okay. So one sec, take that back. It's not exactly let somebody, because that decision has already been made. The frontal lobe has already decided that it has to be done. But the back office does the small work, the deciding how much to do it or making sure that it doesn't exceed the limitations. Now, we spoke about how your supplementary motor cortex has the plan. So why isn't the supplementary motor cortex able to tell the primary motor cortex to execute it? Because the supplementary motor cortex is under continuous inhibition. Okay. Now, what is the concept of inhibition? In the brain, almost 90% of all neurons are inhibited. They are being continuously told not to do something. And so the easiest way to make someone do something is to remove the inhibition. So this is how the brain works. Almost every neural network has this basic concept of inhibition. Okay. So the supplementary motor cortex is not able to tell the primary motor cortex what to do because it is inhibited. Something is stopping it. Okay. Now, what can release the supplementary motor cortex? That is the thalamus. So there is an area in the thalamus called VAVL. It doesn't matter the name, but the thalamus basically can release the supplementary motor cortex. It can tell the supplementary motor cortex to go ahead, execute your plan. So then the supplementary motor cortex can tell the primary motor cortex and so on. So then your right hand will move. Okay. But your thalamus is under inhibition from your globus pallidus. So now you can see how all of this is coming into play. The globus pallidus is inhibiting the thalamus. So if we have to free the thalamus, you have to stop globus pallidus. Okay. Now, what will stop globus pallidus is your putamen and your caudate. So your putamen and your caudate will stop the globus pallidus from acting. And if you stop the globus pallidus, then your thalamus is free. And why should the caudate or the putamen stop the globus pallidus? Because your supplementary motor cortex requests the caudate and the putamen that, listen, I have this plan. I want to move the right hand. Can you please stop globus pallidus so that the thalamus can release me? And this is what is known as the direct pathway. And if this is confusing, don't worry. This is one of the more complicated concepts in neurology, but once you get it, this is hugely rewarding because the same concept repeats everywhere. So we will talk about this in different places also. Even in one of our quarantine Sundays, when we talk about behavior and motivation, we will come back to this. But this is a essential concept in neurology, that when somebody wants to do something, when a neuron wants to act out a plan, it cannot act out directly. It needs to ask permission. It needs to go through this back office, and the back office circuit is like this. So this is a direct pathway. Now the part of the supplementary, when I say supplementary motor cortex, it is a huge area. So not the entire supplementary motor cortex will be asking the caudate. There is a specific area in the supplementary motor cortex that wants to be released. Okay, so think of it like this. If the supplementary motor cortex is a building, the part of the supplementary motor cortex that can move the right hand is probably on one floor. It's on the 10th floor. So that 10th floor will ask for permission to get the thalamus to release it. Now, that is a direct pathway. What happens if, while the thalamus is releasing the 10th floor, what if it accidentally releases the 8th and the 9th or the 11th floor? Because they are all close by. So what if, while releasing the 10th floor, you release the 9th and the 11th? So when you are moving the right hand, you might accidentally move your leg also, or you might move your face also, because the leg, the hand, and the face are close by, as you saw in the homunculus. So in order to prevent accidental release of neighboring structures, you have something called as indirect pathway. So what the indirect pathway does is that if you have a supplementary motor cortex and you want only this area released, the indirect pathway makes sure that the areas which are next to it are doubly inhibited, just to be sure. So the areas right next to the area we want to release, the areas right next to it, the indirect pathway will make sure that they are doubly inhibited. And the way this happens is, it goes through, so the earlier pathway was your supplementary motor cortex, caudate, putamen, globus pallidus, interna, thalamus, and back. So this is something that I didn't mention, that a globus pallidus has two types. One is interna and externa, but right now, for the sake of this discussion, let's forget about it. The only thing that you have to remember is this was the direct pathway. The indirect pathway, what it does is, the caudate and the putamen, while doing the direct pathway, will also give a side channel to globus pallidus externa, which will go to subthalamic nucleus, which will inhibit the neighboring thalamic neurons. You don't have to get too much into this. It is not going to be important for our clinical discussion, but right now all I want to leave you with is the concept. The concept is that your direct pathway will release that exact area that you want to make your movement happen, and your indirect pathway will inhibit the neighboring areas to make sure that no extra movement happens. So that's it. That's all the circuitry we are going to discuss. Now we are going to come back to the clinical scenario. Now, if you want to have a movement, direct pathway makes movement happen. Your indirect pathway prevents unnecessary, or rather your involuntary movement. Now, if you come back all the way to the start of the lecture, when we discussed that there are two types of movement, there is hypo and there is hyper. So what happens in hypo? You can't move. Even when you want to, you can't move. So then the problem will be somewhere in the direct pathway. Does that make sense? Because you want to move, but you can't. That means there's something wrong in the direct pathway so that you can't make movement happen. And if there is movement happening even when you don't want it, that means there is hyperkinetic movements. That means there is something wrong with your indirect pathway. So when your indirect pathway is damaged, you are not able to prevent those unnecessary movements. And if your direct pathway is damaged, you are not able to move even when you want to. Okay, so that is the basic concept of movement disorders. If you go a little bit deeper into it, you'll find that there are specific areas for different disorders. For example, the area known as caudate is what is damaged in cases of chorea, and the area known as substantia nigra. So your substantia nigra is what is damaged in Parkinson's disease, and so on. So your subthalamic nucleus is damaged in Balismus. That you can read about it, and once you follow this circuit and you have this basic concept, and then when you read about all those diseases, it will make a lot more sense. And there is a lot more to go into if you want, but uh, I wanted to complete movement disorder within 45 minutes, and so instead of going too deep into the individual diseases, I thought that the concept was more important, that this is how movement happens, and this is why you get hypokinetic movement disorders and hyperkinetic movement disorders. Now, we'll have a very brief 5-minute discussion on Parkinson. So, Parkinson's disease, essentially, there is a problem with the direct movement pathway. So, what you get is decreased movement. So even when you want to walk fast, you can't walk fast because there's a problem in your direct pathway. So decreased movement is called as bradykinesia. But you also get rigidity and tremor. The reason that this happens is because your extra pyramidal tracts are involved. Now, if you remember when we discussed UMN and LMN, we discussed the pyramidal tracts. We also discussed extrapyramidal system. We briefly touched upon it. The basic concept is that your pyramidal tract is responsible for your movement and your extrapyramidal tract is supportive. It supports the movement. So if there is anything wrong in your extrapyramidal, your movement will happen, but it will not happen perfectly. There will be something wrong. So that something wrong is this. There will be rigidity, which means that even when you are trying to move, there is a lot of resistance to your movement, and there may be tremors. This is the basic triad of Parkinsonism: bradykinesia, rigidity, and tremor. The reason that all these happen is that in your direct pathway, there is a hormone called dopamine. So dopamine is released from your substantia nigra, and for some reason, your levels of dopamine in your brain go down. And because your dopamine goes down, your direct pathway doesn't function the way it's supposed to. And because of this, your movement doesn't happen. Which is why in Parkinson, when we give dopamine, you clear up the direct pathway and you have benefit. So this is the basic concept of Parkinson's disease. Now, Parkinson's disease is just bradykinesia, rigidity, and tremor. You can have other disorders in which your dopamine is lost, but there are other features which are called as Parkinson plus. So you can have autonomic dysfunction, you can have visual hallucinations, you can have involuntary movement disorders. So these are all extra symptoms that are associated with Parkinson. So these are called as Parkinson plus. And the another thing is Parkinson's can be hereditary or acquired. So hereditary Parkinson is when there is a genetic cause of Parkinson, and acquired is when it is caused due to either drugs or some toxins. So the commonest drugs that can cause Parkinson's are your anti-dopaminergic drugs. So any drug that can reduce your dopamine levels will lead to Parkinson's. So I think that is the basic concept of movement disorders and Parkinson. I know that I have not covered a lot of things. I have not gone into the details of any of the hyperkinetic movement disorders, because if you go into one, then you need to cover all of them. And the concept of each one is different. So the concept of chorea is different, dystonia is different, tremor, myoclonus, each one is a completely different concept. But the essence of it is the same. The essence is that all of them stem from some problem in the movement circuit. And I have also not gone into the pathophysiology of Parkinson. So exactly where does dopamine act and how does it act? And I've not gone into the extra motor symptoms of Parkinson. So dopamine acts in a lot of other places also. So your sleep, your appetite, your digestion, all of that gets affected in Parkinson. But there is really no time to go into the details of it. But this is the overall concept. And now, if you have any questions, you can ask. So in this part of the circuit, the indirect part of the circuit, in this area, I didn't go too much into detail because it would have led to some confusion. But what I would suggest is that today would be a very good day to read about your basal ganglia circuit, and there are a few more concepts like how your GPI, your globus pallidus interna, and your substantia nigra are actually the same. So during embryology, like, so when you are as an embryo, they are both part of the same neurons, but then they get separated anatomically, which is why one of them goes into the globus pallidus and the other one goes into the brainstem, but they're actually one and the same. So whenever you, in the circuit, whenever you see GPI, you can substitute it for substantia nigra and they are both similar. So you don't have to remember them both separately. They are both acting as one functional unit, although anatomically they are separate. So these are small things, but when just read the circuit and tomorrow we can discuss these points, because then it would make a lot more sense. Okay. Bhavesh asked, we discussed regarding music releases dopamine. How can this be used in treatment? So music releasing dopamine is a treatment of music in depression. But the more interesting way that music can be used in Parkinson is, okay. Okay, so you have your supplementary motor cortex and you have your basal ganglia. What happens in your normal situation is that your supplementary motor cortex asks permission, your basal ganglia gives permission, and then supplementary motor cortex tells your primary motor cortex, and then movement happens. This is what normally happens. Now, in um, in Parkinson's, this circuit is lost because of lack of dopamine. This circuit is lost. What happens in when you're listening to music? So when you're listening to music, music comes through your ear and you analyze it. It goes to your cortex, to your parietal lobe. It goes to your frontal lobe. It goes to the basal ganglia, and then it goes to your supplementary motor cortex. So as you can see, it sort of it's like a parallel route through a lot of the same areas where your voluntary movement happens, but it is parallel. It is not the same. So because it is parallel, when you move to music, you are using a different circuit, which is not the same circuit that you use when you are moving completely voluntarily without music. So that is why when you are listening to music, or when a Parkinson's patient is listening to music, they are able to move better because they sort of hijack this parallel pathway. Okay. So that is the basic concept. Now, there is still a lot of research going on into this, and it is the exact differences between the two pathways haven't been described entirely because we are still finding out. But this is the basic concept that when you listen to music, we are hijacking parallel pathways that you can then use to move better. Similarly for visual cues. So the idea of visual cues is that suppose this is a Parkinson patient, okay, and you ask the Parkinson patient to move from this point to this point. Now he is moving very slowly, okay, so he's taking around 10 seconds to move from this point to this point, okay. Now what you do is you give a visual cue. You draw a line here and you ask him to step over this line. Now what will happen is he's using a slightly different circuit because now he is seeing the line, he's judging where the line is, he's calculating the distance between him and the line, and then he's stepping over it. So this circuit is slightly different from the one that he's using to voluntarily move. So you can use visual cues, and that's the same way that music also does. You are hijacking a parallel pathway to make you move better. So that's the concept of cues. So audio cues or visual cues. Rishiraj is asked, so as a feel-good hormone, what if level crosses the sensitivity level? So if dopamine decreases, you can have decreased movement. If there is excess dopamine, you have increased movement. So you have hyperkinetic disorders if your dopamine levels increase more than normal.